Oh no.
I think she may have lost connection because I don't see her Hollywood Square.
There she is. She's coming back.
Yes.
Sorry, everyone. It's all right. Go ahead and unmute. You're all right, Dr. Exer. Thank you.
All right. I think I hit the wrong button when the recording thing came up. Anyway, her physical exam has never been all that bad. And when the question last time was, you know, what can we do to kind of speed things along while we're waiting for an endocrinology referral? So you guys made some very helpful suggestions. And since then, we have repeated her parathyroid hormone. It stayed about the same. The last one was 92. It had been 88 initially. And her vitamin D has been normal. And then we did the DEXA. And I had to kind of fight with the radiologist to get the long bone that you had suggested, but we did. And she does indeed have some osteoporosis in the forearm and femoral neck. She's never had a fracture that seemed to be pathological. She's had some fractures from automobile accidents, that sort of thing. The ultrasound showed a possible adenoma at the neck left pole of the thyroid. They recommended a sestamibi scan, and I didn't get a chance to send that out to you, but I am looking at it, and basically it's got intense activity in the region where they saw the nodule on the ultrasound. So I guess the working diagnosis at this point is whether is a functioning adenoma. And so we're thinking to refer her to surgery instead of endocrinology, or maybe in addition to endocrinology. Just thought it would be interesting for you guys to have the follow-up.
Thank you so much, Dr. Rexroad. I can scroll up and down if need be as well. Does anybody have any follow-up questions or comments, please?
Dr. Rexroad, I was just going to say, we so appreciate you presenting the follow-up case. It's always so interesting to see, like, you know, the progression, transition of patients. So we just appreciate you doing that. Thank you.
Well, this has been interesting to me because I've learned a lot as we've been kind of walking through all this. It's taken a little convincing, actually, of the patient and the family that, yeah, you probably do really need surgery, not, you know, medical follow-up here. And I hope I'm telling them the right thing.
So sorry, I was having trouble finding my unmute button. So Dr. Rexroad, I am just going to kind of go back to your case because I missed the first presentation of it and I didn't have time to kind of go through all that. But to kind of summarize, you tell me if I'm right. 68-year-old female with osteoporosis at the forearm has an elevated PTH and an elevated serum corrected calcium and an elevated ionized calcium, right? And do we have a 24-hour urine test on her?
That's the one piece we don't have.
Okay, so when we think about hypercalcemia, the first thing I always try to do is correct it or do an ionized to confirm it's true. And then our algorithm is it PTH driven? Is it not PTH driven? So in our case, it is PTH driven. And then our algorithm is it primary hyperpara or is it FHH? Familial hypercalcemic hypocalciuria. Those are the two diagnoses if we have a high PTH and a high serum calcium. Remember, if it's a low PTH, we have a whole other list of differential diagnoses like cancer, vitamin A toxicity, sarcoid. Your calcium would be high, your PTH would be low. But on this side of the algorithm with a high PTH and a high calcium, our job is to differentiate between primary hyperparathyroidism versus FHH. So in doing that, I always first look at the med list. I saw that lady was on hydrochlorothiazide. So that is an interfering medication because it elevates serum calcium. Were the labs ever done off of hydrochlorothiazide?
Yes, the last set was done off the hydrochlorothiazide. We had stopped that and rechecked, and everything really didn't budge.
Okay, so then the next step is, and you said vitamin D was okay. The next step is doing a 24-hour urine calcium.
Okay.
That is the defining piece of information that helps you differentiate between primary hyperpara and FHH. Most people with severely high calcium that's new, that's typically primary hyperparathyroidism. But the reason why it's important to distinguish is because FHH can present with higher calcium levels, in select cases. It's not as common, but certainly it can. And FHH is not a surgical disease.
Okay.
So remember from like med school, dust off like all that stuff, right?
It's been a long time.
So I know this, but like if I were in a primary care office, I'd be dusting off, I don't know, tons of things that you do every day. I haven't read an x-ray like you were saying in I don't know how long. So it's something I do every day. But if we go back and look at the differentiating feature between primary hyperpara and FHH, the answer to that is in the urine. It's in the 24-hour urine calcium. And we order a urine creatinine with it, a 24-hour urine creatinine for the purpose of calculating what's called the fractional excretion of calcium. Because people who have FHH have high calcium in the blood and low calcium in the urine. So it's low urine calcium. For that reason, they don't develop the typical manifestations of primary hyperparathyroidism because they have low urine calcium. They don't get kidney stones. They don't get nephrocalcinosis. They typically don't get bone pain and fractures. FHH is usually familial, and it's like a calcium sensing receptor issue where their whole lives, they typically have a mildly elevated PTH and a mildly elevated calcium, and we do nothing for it because it doesn't cause medical disease. So the other side of that is primary hyperparathyroidism. Going back to medical school, remember psychiatric overtones, kidney stones, abdominal groan. So that mnemonic that we use to remember all the clinical manifestations that primary hyperparathyroidism does cause. It does cause disease. So that's why we surgically treat primary hyperpara and we don't treat FHH. Now, does everybody that has primary hyperparathyroidism need to see a surgeon? No. There are surgical indications to send somebody to surgery. Your patient meets them. If she does have primary hyperpara, evidenced by her fractional excretion of calcium, say she does have it, then she would meet surgical criteria by the fact that she has osteoporosis at her forearm, right? Mm-hmm. And then the other criteria would be a serum calcium 1 milligram per deciliter above the upper limit of normal off of hydrochlorothiazide. The other criteria would be age less than 50, GFR that's less than 60, because if you have kidney disease, this is going to make it much worse. And then if you have a 24-hour urine calcium greater than 200, if you have pathologic fractures or osteoporosis, those are all the conditions that identify a patient who would benefit from surgery. So not every patient goes to surgery, but that patient should because of the degree of elevation of the calcium and because of their osteoporosis. Now, the question is, do you treat it? I would do a 24-hour urine and a 24-hour creatinine, calculate her fractional excretion of calcium, make sure she has primary hyperpara, and then I would start her on Sensipar. And I would do like 30 milligrams BID, and then I titrate that typically every 2 weeks. So then I do a serum calcium in 2 weeks' time and go up on the dose if I need to. The other question is, when do I admit them? So calcium is graded by the degree of elevation of serum calcium. So 12 to 14. Usually most people kind of deal okay with that. They may have some symptoms, but I don't really admit them until calcium is persistently above 14. And then I'll admit them for like fluids. I don't know if you guys do fluids in your office, but IV fluids is one of the big things. And then Sensipar you can give if it is PTH mediated. Bisphosphonates and calcitonin are therapies that we use in the inpatient setting. Because she has osteoporosis, you don't have to just use Sensipar. You can start Sensipar and also start a bisphosphonate. And I typically use the bisphosphonates as opposed to the other therapies like Prolia. There's a little bit more data for using like Reclast or one of the IV bisphosphonates as opposed to Prolia. So you can treat them concomitantly. So the Sensipar 30 twice a day and some Reclast. If you dose her with Reclast, it's usually you give her like IV once a year. The dose is 5 milligrams for osteoporosis. So, and then once you definitively say it's primary hyperpara, and I would have her see an endocrinologist, then you'd want her to see an endocrine surgeon. I think that it's always very premature to do a sestamibi scan until you definitively, so she probably has primary hyperpara, but we biochemically diagnose that first. The scan is never diagnostic. Never. The scan is only a tool that we use to help the surgeon localize the gland. So that is not at all a part of diagnosis.
No, wish the radiologist had said that.
I think that I have mad respect for PCPs. So, if you were to put me in your place, I would be here saying, I wish somebody would help me with that medicine. I didn't know. So we all have different expertise, and it's not your fault. I think all your questions are wonderful, and that's why we do this, is to each other manage patients. So please don't feel like you made any mistakes. You didn't do anything wrong. Your case is awesome. You're managing it great. I think that I'm telling you this because I really enjoy learning medicine all the time. So I just appreciate why we do what we do. But I think you're doing a fine job of taking care of her. It's just
we need one more piece.
when you send her to me. So this is, the next step.
Okay. Well, we will. We'll try to get that.
Yeah, and I think stopping the hydrochlorothiazide indefinitely is going to help her. And just
we already did.
Okay.
We did that probably a month and a half ago.
Okay. Yeah. Sometimes it's temporarily held for testing, but it's just not a good agent when someone has hypercalcemia. So, okay. Any other questions?
I don't think so. I think that this has been helpful to just kind of review it again and see that, the missing piece and why we need it. That's been very helpful.
Yeah. So high PTH, high calcium, 2 things: primary hyperpara, FHH. The answer is in the urine.
Got it. All right. Thanks.
Of course.
Excellent. Thank you so much, both of you. Dr. G, thank you very, very much for being here and assisting with that case and all the kind words. And also thank you, Dr. Rexroad, for all that you do as well. And I'm curious to see where this goes. So if you ever want to do a follow-up on a follow-up, we're open to that, because then it's great. It's a great like teaching tool too. So that would be excellent to know. And it's nice to see where this leads for us on our end, for Mitra and myself. So we thank you. All right, Dr. Giordano, do you want me to share the slides for you today?
Yeah, I just had a quick note too. I think I was assigned like thyroid diseases and their treatments, but that was so broad that I couldn't possibly do all of that in one lecture. So I made this hypothyroid because I felt like that was one of the more common things that primary care is dealing with. I think I can do hyperthyroid or thyroid nodules or other thyroid pathologies if people want those things, but I just chose to focus on hypothyroid because it's more common.
Absolutely. Sorry, I was making sure I was muted. Yeah, that's great. No, we want feedback. So if anybody, after watching the video want to message us, that'd be excellent, just to give us some, guidance on what you guys need to hear and learn. So I will go ahead and share your slides, and I appreciate that. Give me one moment, please.
Okay. I'm just gonna have to. Okay. So let's talk about hypothyroidism. Our objectives will be to briefly review anatomy of the thyroid gland, review thyroid hormone production and regulation, thyroid function testing, and then diagnosis and treatment. Can you guys see me okay? Is that okay? Yeah. Is it too much of a glare? You can see me all right too?
See you fine. Thank you.
I'm moving myself around here so that the moon doesn't fall backwards as I'm talking.
Yeah.
Okay, good. And feel free to just stop as we go and ask questions if there are any. Okay, so here is our thyroid gland. It's the tan appearing gland that's sitting over our windpipe, which is in blue, or the trachea. We have a right lobe and a left lobe. I always tell people it's the butterfly-shaped gland that sits in the neck. There's a little bridge that connects the right part to the left part. That little bridge is called the isthmus. Next slide, please. So if we zoom in on what a typical cell within the thyroid gland looks like, I like to think of it as the worker bees of the thyroid gland. And I say this is where all the thyroid hormone magic happens. So if you look at the very right hand side of the picture, you'll see the bloodstream where iodine, through the action of the iodine sodium symporter, gets shuttled into the cell. Iodine then gets put onto thyroglobulin. And then, as you can see at the other side of the cell, it gets exported, oxidized, and then imported back into the cell. At that point, it's thyroid hormone. And you can see over here, I don't have kind of a pointer, but in the lower right-hand side of the slide, you can see thyroxine and Triiodothyronine. Those just simply mean how many iodine atoms were put on to that thyroglobulin protein. That's all that means. So the prefix tri means 3 iodines, and then thyroxine means 4 iodines. So that in turn gets then put out into the bloodstream, and that is what we call the free kind of circulating thyroid hormones that have actions on all the glands in our body. Next slide, please. So why is thyroid hormone even important? It plays a role in every tissue within the body: lipid and carbohydrate metabolism, growth and development, which is very, very necessary in fetal development. I can't emphasize that enough. So women that are trying to conceive or who are pregnant, it's very critical to have adequate amounts of thyroid hormone, so much so that we have different targets of thyroid hormone levels within pregnancy. It's also important in the cardiovascular system, nervous system, reproductive and digestive system. So basically, thyroid hormone is used everywhere for our metabolism and control of all of our organs. Next slide, please. I like to think about the thyroid and the pituitary gland like a heater in a thermostat. So if we think about in our own house, if our heat starts to go down, the thermostat will kick in to increase your heat, right? So then let's go to the next slide and talk about kind of how physiology works in our own thermostat. So this is the feedback loop of thyroid hormone. So if we look at the thyroid gland down at the bottom of the slide, think about that like the heat in your house, okay? That's the T4 and the T3 that are being produced by your thyroid gland. Think about that like the heat. So it's getting cold in your house. Those levels are going down. That sends a feedback mechanism to your hypothalamus and your pituitary gland in your brain and says, hey, it's too cold in the house. Like, you need to kick in. The thermostat needs to kick in. So you think about your hypothalamus and your pituitary is like the thermostat. The hypothalamus releases what's called thyroid releasing hormone, TRH, and then the pituitary in turn makes something called TSH, thyroid stimulating hormone. I like to joke around and call it thyroid slapping hormone because it is important to slap your thyroid and tell it, hey, wake up. So when your heat in your house goes low, that T4 and T3 are low. In turn, your TSH is going to be high. Okay, next slide. Primary hypothyroidism is just what we described. So it's a problem at the level of the thyroid gland itself. There's broken heat, the thermostat, your hypothalamus and your pituitary, they're working just fine. It's a problem at the level of the thyroid itself. Lots of things can cause that we'll review. So in primary hypothyroidism, a glandular problem, and that's going to have a pattern of a high TSH and a low T4 and T3. Next slide, please. Okay. I put this slide in because the most common cause of hypothyroidism in the United States is something called Hashimoto's disease. Hashimoto was a brilliant Japanese physician who first described this disease, and so it's named after that physician. Basically, it's an autoimmune disease where we have death of the thyroid cells because you're having an autoimmune attack on the cells of the thyroid gland. That's abnormal. Your body shouldn't be attacking itself, but therein lies the problem of autoimmune disease. So it's an autoreactive disease where you have these antibodies floating around that you can see in the little or figure, the Y-shaped antibodies that attack the thyroid cells and then they die. So over time, people need thyroid hormone in most cases when they have positive thyroid antibodies or Hashimoto's disease. On imaging, you may see that an ultrasound will say heterogeneous or homogeneous tissue. That is classic to describe Hashimoto's disease because we can look at an image of a thyroid and say, you know what, that person probably has Hashimoto's disease based upon the pattern of tissue in the ultrasound. So when we think about a normal thyroid gland that's supposed to be smooth, we think of, I like to teach it in terms of fruit. So like an orange's skin is nice and smooth. But if we think about a gland that has destruction from Hashimoto's disease, it typically becomes much larger and fibrotic, and it's harder on exam than nice soft tissue. And it feels kind of like the skin of a pineapple, where it's kind of jaggedy and rough. And we see that on ultrasound imaging too, where that tissue just looks very rough. Smooth tissue is described as homogeneous. That means the same across the whole thyroid gland. Heterogeneous means different. The prefixes just mean same and different. So heterogeneous tissue, when you see an ultrasound, just means the tissue looks different in spots and has a lot of inflammation. Next slide, please. So then let's talk about secondary and tertiary hypothyroidism. Not as common. These are also labeled central hypothyroidism. So remember, I said primary is when there's problem at the thyroid gland itself. So this in secondary and tertiary is a problem with either the hypothalamus or the pituitary in the brain. There's many causes of that we will go through as well, but we'll identify kind of what the pattern of thyroid labs should look at first. So if we knock out the hypothalamus and the pituitary, we're going to see that the TSH is low or inappropriately normal. So we could miss central hypothyroidism if we don't order a T4 or a T3 to look at the functioning of the whole system. So in this case, you're going to have a low TSH and a low T4. What should happen when your T4 goes down is that your TSH should respond to that, right? Like our heater and our thermostat. In this case, your hypothalamus or your pituitary are broken and they don't respond. That's why we say inappropriately normal. The TSH is in a normal range, but it should be very high. So it's inappropriately normal considering that the T4 is low. Okay, next slide. Subclinical hypothyroidism. This is a problem at the level of the thyroid gland when early on it starts to release less free circulating thyroid hormone levels. And that's sensed by the hypothalamus and the pituitary. So you may have, in this case, a very mildly elevated TSH, but you're going to have a normal T4 and T3. So the heater is struggling and the thermostat's working just fine. Your TSH is going up, your hypothalamus and your pituitary are doing their job. It's just you're at the level of the gland, it's struggling and not putting out enough thyroid hormone. Next slide, please. So if we talk about our thyroid labs, there's so many tests. Not all of them are useful in all situations. We have kind of free and total T4 and free and total T3, a TSH, and antithyroid antibodies. The TSH is definitely the most sensitive indicator of thyroid disease. But as I mentioned, if you're worried that somebody may have central hypothyroidism, and again, we're going to go through those causes, say they've had a concussion or a brain surgery or pituitary surgery, then we could miss it if we don't order the TSH. So keep that in mind. Next slide, please. Okay, so tetraiodothyroxine, thyroxine, or T4. I told you all this means is that there's 4 iodines attached to our thyroglobulin. This is the major hormone secreted by the thyroid. The amount produced is controlled by TSH from the pituitary. This comes entirely from the thyroid gland. There's no other gland in your body that makes thyroid hormone. T4 gets converted to T3 at the level of each organ. So I oftentimes, I think especially now in 2023, I feel more than ever, I have people come in and ask, well, I want all my thyroid hormones and can you treat me with Cytomel and levothyroxine? So T4 and T3. And historically, we only treated patients with hypothyroidism with levothyroxine or T4 because of this principle that T4 gets converted to T3 at the level of each of our organs. So we really didn't feel there was a physiologic need to give T3 in addition to T4. There are some instances when I do give both. When I see people in the hospital in Myxedema Coma, sometimes we do give T3 and T4 concomitantly. And then if I have somebody that's really struggling on T4 and has low mood, low energy, sometimes I'll try a small dose of Cytomel and see if it makes an impact. Cytomel is T3. Okay, so next slide. So T3, this is Triiodothyronine. This is the biologically active thyroid hormone. About 20% is made in the thyroid gland itself, up there coming out of the thyroid. As you see, T4 is the most predominant hormone from the thyroid gland, about 80%. And then this picture is showing just what we discussed. So at the level of the liver and the kidney, you're seeing the T4 gets shunted into T3 based on the need of those individual organs. So next slide, please. We said TSH, thyroid stimulating hormone, is the best way to initially test for thyroid function. It's the most sensitive screening test for both hypo and hyperthyroidism. It's a very early warning system before the actual levels of free circulating thyroid hormone in the body become too low or too high. So your pituitary is exquisitely sensitive to just very small fluctuations in your free circulating thyroid hormones. Next slide, please. Thyroid antibodies can be confusing. I think the key point that I want to get across through this slide is that they are not exclusive to one disease. So you can see that there is overlapping antibodies that are positive in all thyroid conditions. And I like to think of these autoimmune diseases kind of on a spectrum. Generally speaking, somebody has Hashimoto's disease, their antibody that will be positive is the thyroid peroxidase antibody, or TPO. But please note that, you know, that's up in the tan. It's an overlapping kind of antibody. And I even sometimes see those positive in Graves' disease as well. So if we look in the pink where Graves' disease is, we typically see thyroid stimulating antibodies, again, overlapping. So if you look all the way up, you can see thyroid stimulating antibodies in Hashimoto's disease as well. You can see something called hashitoxicosis, which is alternating Graves. It's alternating hyper and hypothyroidism. So I think the main point about this is if you see positive antibodies that don't really make sense, if your patient has hypothyroidism, then most commonly we want to check a TPO. If your patient is more likely to have, say, Graves' disease biochemically, where they're overactive, then the antibody you want to look at is your TSI, or thyroid stimulating immunoglobulin, or antibody. Next slide, please. So causes of hypothyroidism, Hashimoto's is by far the most common. We talked about that being autoimmune or lymphocytic infiltration of the thyroid gland and destruction of the gland. It's the most common cause in the United States. You typically see positive TPO antibodies, although patients do have antibody negative Hashimoto's as well. There's also permanent damage to the thyroid gland from radiation, surgical removal of the thyroid gland, radioactive iodine ablation for a history of Graves' disease. Thyroiditis, which can be postpartum or de Quervain, that's typically transient and resolves on its own. Medications, lots of them are involved with thyroid disease in general, but hypothyroidism specifically, lithium, interferon alpha, interleukins, amiodarone, tyrosine kinase inhibitors like imatinib, all the new checkpoint inhibitor immunotherapies have definitely hyper and hypothyroid issues and endocrine issues overall. Infiltrative diseases like sarcoid and hemochromatosis, congenital like thyroidogenesis or dyshormonogenesis, damage to the hypothalamus or pituitary like brain tumors, radiation surgeries, infiltrative diseases to the pituitary, an infarct of the pituitary, or Sheehan syndrome. Next slide, please. So what are the symptoms when someone has hypothyroidism? Fatigue, weight gain, cold intolerance, constipation, impaired concentration and short-term memory, dry skin, swelling, mood changes, depression, cognitive delay, muscle cramping, and menstrual changes. I would caution you that these symptoms overlap with a billion other medical problems. So if your patient's TSH and T4 are solidly normal, they do not have hypothyroidism. Does not matter if they have these symptoms. If they have biochemical euthyroidism, they are not hypothyroid. It is biochemical diagnosis. Next slide. Physical exam findings: hypothermia, diastolic hypertension, bradycardia, enlarged thyroid, dry skin, cold skin, paler, brittle hair, delay in recovery of their deep tension reflexes, mental status changes, slowed speech, periorbital edema, and I have a good picture of that coming up, enlarged tongue, puffy faces, hoarseness of voice. Okay, so our first case is a 65-year-old female transferred from a SNF for acute mental status change and bradycardia. The SNF reports she's been refusing all meds for the past few weeks. She's cachexic, she has pretibial and periorbital edema. And as you can see, the periorbital edema, it is in fact periorbital. So it's entirely surrounding the whole eye. And it typically does look like that in myxedema, where it just looks like bags full of water. She was intubated, heart rate was 40. She was hypotensive, hypothermic, hyponatremic. TSH level was 40. Her free T4, which was her circulating active thyroid hormone, was completely undetectable. Her thyroid peroxidase antibodies were positive, very markedly positive at 1,000. Medical history includes strokes. She's had hypothyroidism, hyperlipidemia, hypertension, coronary artery disease. Her meds include aspirin, synthroid-statin, and trazodone. Next slide, please. So what do you think that this woman has?
Feel free to chat it in or unmute.
She hasn't been taking care of her hypothyroidism, so it's probably exacerbated.
Bingo. That's the most common cause of uncontrolled hypothyroidism is non-compliance with the medication, or not taking it right, or forgetting it. Next slide, please. So do you think that she has severe hypothyroidism? She's intubated, she's bradycardic. This is pretty severe. So hypothyroidism is really on a scale of severity. Overt hypothyroidism in clinic, people are mentating, talking just fine. The worst possible case scenario is when you see them in the hospital and they are intubated, they have airway obstruction, and they're in Myxedema Coma. This is the most extreme form of hypothyroidism. It's defined by altered mental state and not biochemically. It is not based upon your thyroid function tests, although it does require that you're biochemically hypothyroid, but you can have a patient that's in Myxedema Coma with a TSH of 10 or 20. So it's not a biochemical diagnosis, it's clinical. So there's decreased metabolic state, hypothermia, hypotension, bradycardia, hypoventilation, hypoglycemia, hyponatremia, altered mental status, and the diagnosis requires a very high degree of suspicion because these people need treated swiftly. There is a very high mortality rate associated with Myxedema Coma. Next slide, please. This is the spectrum that I was referring to. So if we think about subclinical hypothyroidism, that's how it begins. Overt hypothyroidism is where it gets worse. And then the worst is Myxedema Coma. Next slide, please. This is the scoring scale in the inpatient setting when I'm trying to determine how aggressively I need to treat this patient. This is called the diagnostic scoring system for Myxedema Coma. A score after you've tallied up, their CNS, their GI findings, their CV dysfunction, metabolic dysfunction, their temperature. You add up all your points. If it's greater than 60, that person is at a very high risk of Myxedema Coma. Next slide, please. So to treat Myxedema Coma, this is ICU care and supportive aimed at restoring euthyroid state. We use stress dose steroids because we want to always consider hypothyroidism is the most common kind of autoimmune hypothyroid disease. So we want to consider concomitant adrenal insufficiency as well. And remember that autoimmune diseases run in clusters, and the most common cause of hypothyroidism in the United States is Hashimoto's. So we treat with stress dose steroids as we're considering concomitant adrenal insufficiency, but also if the patient is septic or you're treating other kind of supportive issues in this Myxedema patient. The levothyroxine dose we give is typically between 200 and 400 micrograms IV. If elderly with cardiac disease, I treat on the lower end of that spectrum. We treat with IV levothyroxine until they're clinically improved, their vitals are stable, and also because if you saw that patient in the picture, they were very edematous with anasarca. And so we assume that their bowel wall is incredibly edematous as well. And so we assume that they're not really going to take much oral or absorb it well if they even are able to take in oral therapy. I will say that it's been an incredible challenge to get IV levothyroxine in this inpatient setting. It is more costly, but nonetheless, in people who are in Myxedema Coma, that is actually what's recommended in our guideline. Once we treat them with levothyroxine, we trend their T4 every 2 to 3 days. Remember that the TSH, because it's a feedback mechanism, is going to take time for the TSH to come down. So we use the free T4 in this acute inpatient setting to give us an idea of when it's safe to start oral levothyroxine. Then we search for underlying causes that may have precipitated the Myxedema Coma, because some people live with like a TSH of 50 or 100, and then they may have like an infection of the foot or a heart attack or something that kind of pushes them over the edge into Myxedema Coma. So we look for a precipitant as well. Next slide, please. Okay, so outpatient treatment, the mainstay of thyroid hormone replacement is levothyroxine therapy, which is T4. There's many different brands: Synthroid, levothyroxine, Euthrox, Levoxyl, Unithroid. Now there's also Tyrosine, which is liquid levothyroxine, and also in a capsule. We have pure liquid formations like Thyroquidity. And then as a last resort, I do have some people who don't absorb any form of thyroid hormone. I had a woman that was on IM injections twice a week of 500 micrograms, and that was the only thing that stabilized her thyroid levels. So that's a last case resort. It's rare, but it can be used. If you suspect somebody has like malabsorption issues, allergy, like lactose issues or malabsorption for any cause, celiac, bariatric surgeries, etc., you could consider liquid or capsule, which may be absorbed a little bit better. We typically start a weight-based dose for an adult. It's typically 1.6 or 1.7 micrograms per kilogram per day. unless if they're cardiac risk or if they're elderly. Elderly, I consider 65 or older. If they're, again, this is outpatient. If they're elderly in the outpatient setting, I usually start like 25 micrograms and titrate it up because there's really no urgency in treating hypothyroidism if they're not in myxedema coma. So there's no need to start an elderly patient on a high dose if they're not in myxedema coma and they're in the outpatient setting. So again, I do like 25 and just titrate up every couple weeks if they're tolerating it. Next slide, please. Okay, so an important part of thyroid hormone therapy. Next slide. Really critical to teach them how to take thyroid hormone the right way. So first thing in the morning, it doesn't always have to be in the morning. If they're better at, if they're a night shift worker, if they're, wherever they're most likely to take it habitually is when they should take it. And on an empty stomach. T4 likes to bind to calcium and other things, and it's absorbed less well. So I usually tell people to wait an hour to eat, or an hour to take any other pills or vitamins. And this allows for the most kind of consistent absorption. Next slide, please. Once you start the dose, you want to follow up with a TSH and a free T4 level in 6 weeks' time, which is how long it takes to reach steady state, to assess your dose. And then I usually adjust the dose every 6 weeks. I aim for a TSH in most people from 1 to 2.5 for just general hypothyroidism. Next slide, please. In subclinical hypothyroidism, if this is again a normal free T4 and an elevated TSH, the question is, do we treat or not? If they're trying to get pregnant or they're pregnant, absolutely have to treat. And pregnant women or women that want to conceive, they are considered hypothyroid if their TSH is greater than 2.5. That's a really important point. Everybody else we consider treating if they're really symptomatic. If their TSH is greater than 10, I treat it. And then that in-between group, if their TSH is hovering between 4 and 10 and they have a normal free T4, it really depends on their symptoms. Next slide, please. So if they're sleepy, gaining weight, if their TPO antibodies are positive, then I usually do a small dose and I titrate it up to see if they're getting any benefit out of thyroid hormone. Alternatively, if they don't want to start medicines, it's okay to monitor. And if they don't have symptoms, repeat the labs in 4 to 6 months. I do find, clinically speaking, I never have people anymore that kind of want to wait and watch. I feel like most people do want treatment right out of the gate, and that's kind of all comers. So I very rarely have anybody that does kind of a wait and watch serial lab type thing, but it's always an option. Next slide, please. Any questions?
Yeah, a couple. Is I think, people are reading, and I constantly get the people who have that constellation of symptoms who come in. They've got a normal TSH and free T4, and then they get in my face and say, "You didn't check my T3."
Yeah.
Or, there's no point, is there?
There's no point. So in hypothyroidism, there is absolutely no reason to check it.
Okay.
Even I have some people say, well, what if my T4 doesn't get converted to my T3? We would know that because T3 is one of the most potent feedback inhibitors to your pituitary. So your TSH would be high.
Okay. That I like that. That's a good thing to throw into the conversation.
Yeah. So there's really no reason in the setting of and I get that all the time. People come in and demand a full thyroid panel from me all day, every day. Like more than I could ever tell. I get the question, can you please check every single hormone? But it's honestly not indicated, and it's an expense to them and to healthcare to do so. And the only time a T3 is really used is hyperthyroidism. It's the complete opposite. So hyperthyroidism is when your thyroid gland makes too much thyroid hormone. And that can be due to what's called T3 toxicosis. So we check T3 in hyperthyroidism, not hypo. Some people will say, well, what about, reverse T3 and all this stuff? Honestly, the data says in settings of sick euthyroidism, you can check it. I never send it, Carmen. I sent it maybe twice in my entire career since 2009. The reason being because when I'm on patient in call and there's somebody that's in the ICU with sick hypothyroidism, it's not that they're truly hypothyroid. It's just that they're critically ill and they have a pattern of sick thyroid disease. In those cases, we sometimes send a reverse T3 to see what the pattern is, but that reverse T3 usually takes 2 to 3 weeks to come back. So I don't even bother sending it because I need that answer here and now to make a judgment on hypothyroidism versus sick thyroid disease. So that's really the only time that I would even consider doing reverse T3s. But other than that, I don't order a T3. And no, you do order it for a diagnosis.
Yeah, and it's those people in between that it's a difficult conversation, I find, because okay, your TSH is 6, you're not having any, you went to a health fair, your TSH is 6, you come in, I need to be treated for my thyroid. Well, no, you don't necessarily. And the other question I have for you is, how do you adjust with age? I mean, what does the normal TSH, do we treat less as people get older?
So there was a study through the NHANES National Health and Examination Survey, and that worked to try to define what a quote unquote normal TSH should be and standardize kind of a TSH level. And that study did show that as we age, we can see a higher TSH level. So it's not uncommon for like an octogenarian to have a TSH of 8 and a normal free T4 level. Okay. So that doesn't necessarily need treated. You're right. As we age, our TSH can increase over time. That's not pathologic per se. That was shown in the NHANES data. So you don't have to treat that. As long as their T4 is normal and they feel good, it's okay to monitor that TSH. I feel like the thyroid gets blamed for so many things though. And so just realistically speaking, by the time someone sees me, they've usually been told that like their thyroid is the cause of everything. And so I'm already in a corner because they've been told that it caused weight gain, hair loss, dry skin, depression, constipation, all of the problems that they're experiencing, right? And so most people really demand some type of therapy. And if in those cases, if it's an elderly person older than 65, I give them 25 micrograms of Synthroid, and then I just check their labs every 4 weeks and increase the dose until I get a normal TSH. And then most of the time, once their TSH is normal, they do their own experiment and those things don't just go away. And so then you can take out hypothyroidism as something in the differential for what's really causing all their symptoms.
Right. And yeah, because I get that a lot too. It's like somebody they're on levothyroxine, they've got normal labs and they're still having all these symptoms. You're not treating my thyroid adequately. And well, yes, I am. We got to look for other things.
It's true. You're not alone. We talk about this we commiserate because it really does get kind of exhausting trying to tell all of our patients that please give us a little trust that, if your thyroid levels are in the normal range, the cause of your symptoms is not hypothyroidism anymore. And that's a hard discussion. It's one I have many, many times a day
Mhm.
And then I just encourage them to get other markers for weight gain. It's mainly weight gain and fatigue that people say is their thyroid, but there's a billion things that cause weight gain and fatigue. And I try to just encourage them to have a workup for, have you seen a nutritionist? What's your diet like? Do you have B12 deficiency, vitamin D deficiency? How much do you exercise? Do you have other autoimmune lupus, Sjogren's? Do you have neurological, there's so many things that cause weight gain and fatigue that as long as I treat the thyroid and their TSH and their T4 are normal, then it's not the thyroid.
Yes, thank you so much, everyone. And thank you, Dr. G. Thank you, Dr. Rexer, for your questions, and thanks for joining us today. For the interest of time, though, we're going to have to cut it down. But we will be here next time, and please bring questions that doesn't have to relate to the topic of the discussion as well. So the next time we'll meet is July 26th, and that will be a diabetes overview. Thank you so much, everyone. Have a great rest of your week.
Thanks.